Hi, my name is Sheth, and it's a pleasure to talk to you about neurosurgery for psychiatric disorders. I'm a neurosurgeon at Baylor College of Medicine in Houston, Texas, and it's a topic that I find very interesting. I hope you will too. These are some disclosures, none of which are relevant to this talk, nor are the funding sources for this talk. Uh, Stereotactic neurosurgery, which is, of course, the basis of how we do many procedures these days, really began in the field of psychiatry. So this is the original monograph from Spiegel and Weisses of 1947. And you can see here in the blown up region, the procedure that was performed is a medial thalamotomy that was used to treat an emotional disorder, a behavioral disorder, a psychiatric disorder is what we would call it now, not a movement disorder. So really, psychiatric procedures are really the basis of the need to develop stereotactic procedures in general. Over the next several years, a number of ablative procedures are performed and canonized. The anterior capsulotomy, shown here is one example, still very much in use today. This, of course, was initially done with radiofrequency and radiosurgery, and now it can be done with any of those, also with laser ablation, focused ultrasound, a number of other techniques. So these ablative procedures are still alive and well today. I'm going to focus really on DBS, deep brain stimulation, and I'm going to focus on two particular disorders, OCD and depression, as examples of psychiatric disorders treated with neurosurgery that are the most commonly studied today. So we'll start with OCD, which is characterized by obsessions and compulsions. It's fairly common, 2 to 3% of the population does have OCD, and around 20% of those people could be refractory to conventional treatments and need neurosurgical intervention. The initial attempts at DBS for OCD really followed from the capsulotomy literature targeting the anterior limb of the internal capsule. This is now, a quarter century old, late 1990s, original monograph in 4 subjects here treated with DBS for OCD with electrodes, as you can see here, kind of spanning the height of the internal capsule in front of the genu, the anterior limb. And this led to further studies in larger groups. This one, a multi-center study from North America and Europe with 26 patients. Inclusion criteria shown here. These are pretty much the same as they are even now. OCD, a diagnosis for a certain amount of time, at least several years. Of course, refractory to medical and psychotherapy. A severity as indicated by a certain score on the severity scale. This study did lead to the humanitarian device exemption status of DBS for OCD. These are the results shown here, published now, in 2010, where you see over the months shown here on the x-axis, this decrease in some severity of the symptom score used to follow OCD symptoms. And these are patients who are, of course, refractory to everything else that they've tried conventionally before that. And so this was very promising. And this did lead to the humanitarian device exemption, which is the form of approval that we do have for DBS for OCD. This is, again, targeting this area of the anterior limb of the internal capsule. The abbreviation used here is the ventral capsule. This is the ventral part of the anterior limb of the internal capsule. And just below it, the ventral striatum, which includes the nucleus accumbens. So that is the target that has this HDE approval that is used here in this country. Another target that is also used in other places, Europe and others, is the subthalamic nucleus. As shown here, this green area is the part that you would target for movement disorders, Parkinson's, the dorsolateral area, but the very ventromedial area, shown here in yellow, is the target for OCD. This is a nice blinded, sham-controlled crossover trial published in 2008 that established efficacy of DBS for OCD targeting this anteromedial STN. Where is OCD going in the future in terms of DBS treatment? Really focusing on 2 main categories. One is anatomy and one is physiology. An example of the anatomy question is shown here. This is a nice paper talking about the circuit that's engaged by DBS for OCD, which is a circuit that involves much of the frontal cortex, especially prefrontal cortex, ventral parts of the striatum and thalamus, and the rest of the basal ganglia. We access that really by putting this electrode in the white matter in the ventral part of the anterior limb, so that from one area in a bottleneck sort of way, we can affect a large cortico-basal ganglia thalamocortical circuit. So there's a lot of nice anatomy work that's been done in monkeys with track tracing and with human diffusion imaging. this is some nice work that is multi-center from many centers in North America and Europe, several score patients put together to kind of identify this connectomic profile of effective connectivity. We've also done some work here in a blinded fashion by sharing anatomy and withholding outcomes, and then showing that the location of the contact can predict the outcome. So much more work will be done here in order to help us understand the anatomical connectivity of effective regions, of this portion of the anterior limb of the internal capsule, so that we can, better predict how someone's going to do and better know where to place the electrode. The second, I think, important uh, area for growth really is the physiology and the understanding of the neural basis of the symptoms and their improvement. So this is some work published just in 2024, where we were able to show with onboard recordings on the DBS device a prediction of clinical outcome based on these neural recordings. So these recordings were done over months and really over years. You see here, this is days since activation. This goes out to over 800 days of recordings. And we look for this certain pattern of activity that changes following DBS response. And based on that, we can, make a prediction of how someone is going to do just with a few days worth of these on-device recordings. And the bottom line here is that there's a certain periodicity and predictability of the signal when they're in their sick state prior to initiation of DBS. And that predictability and periodicity decreases over time with clinical response, such that when someone is in a clinical response state, there's a more stochastic pattern of activity in this ventral capsule, ventral striatum area, which perhaps allows for better reward-motivated behavior. And so we can really predict whether someone is going to is in a clinical response state or not, just from these short recordings. I think this kind of work will also help demystify programming strategies, because programming of DBS for OCD is challenging because there's a time delay between a change in the programming parameters and an outcome. And so if we have this neural signal that can help us tell us that we're on the right track, then I think that'll be helpful for more centers being able to do this. So switching gears to depression, of course, a very common psychiatric disorder affecting tens of percents of individuals in this country and in the world. The story of DBS for depression involves many different targets. I'm going to just talk about two of them. One of them is the same as I showed you before, the ventral capsule, ventral striatum. This story actually comes out of the DBS for OCD story, because many of those patients with OCD had comorbid severe depression, which also improved. And that led to this study in 15 patients targeting the same region, that ventral capsule area, but for treatment-resistant depression specifically. And you can see here, again, the change over time in terms of depression severity over months. And again, these are patients who have failed medical therapy, behavioral therapy, and most of these have failed electroconvulsive therapy. So very refractory patients. And you can see here, more than half of them, 53% response rate at last follow-up. That study and others like it led to this industry-sponsored sham-controlled randomized trial to try to establish, an FDA indication. It was set up as implant and then immediate randomization to on versus off stimulation, powered for over 200 patients, but at an unplanned kind of early interim analysis, after just a couple dozen patients were enrolled, they looked at the data and they did not see any difference between active and sham. Again, not powered to see a difference yet, but based on these results, the industry sponsor stopped this trial. This is called the RECLAIM trial. So this, some people would say, is a failed trial. Really, it's an aborted, incomplete trial, but that was not looking like it was going to meet its endpoint. Interestingly, at the same time, in the same target in Holland, this trial was happening with a very different design, where after implant, patients had open label optimization for up to a year in order to explore the stimulation parameter space and find parameters that were ideally suited for them. And then they underwent a blinded crossover discontinuation of therapy to disambiguate a true response from a sham response. And the results here were very encouraging. The sham patients, remained at a high symptom regime, whereas the active patients, with active DPS, got better. So same target, very different results, and perhaps indicating that we need more time and more experience, within each individual patient to find optimal stimulation parameters and allow the networks to be treated by DBS in order to reduce their symptoms. The other target I want to talk about is the subcallosal cingulate. So this is the area of the cingulate cortex below the genu of the corpus callosum. Very different kind of way that this target was investigated. It came out of some initial imaging studies showing that activity in this area changes when someone is depressed versus not. And that led to the initial studies of placing a DBS electrode into this area, turning it on, and initially in open label, unblinded studies, getting these promising results of 4 out of 6 responders. The PET signal also reversed in those that responded into a more healthy looking appearance. This led to a few additional studies, in increasing numbers of patients, still all open label and unblinded, but that established a lot of optimism for this target. In some of these, as in the one shown here, a 90+% response rate, again, in the sickest of the sick, treatment-resistant depression patients. This led to another industry-sponsored, blinded, sham-controlled randomized trial called Broaden, also powered for just over 200 patients. Similar design, a little bit longer blinded period of 6 months in this study, but immediate split to active versus sham response. There's a planned interim analysis at about halfway through, where they looked at the results, and the active response rate was really no different than the sham response rate. And so again, the industry sponsor for this trial also decided to stop the trial, pull the funding. Interestingly, the open label follow-up in the patients that were followed afterwards did show improvement, in half of them with a response rate that was, that'd be very acceptable. But this was after the trial was over. So two big trials, multi-million-dollar trials sponsored by industry, neither of which could demonstrate success of the primary endpoint. What's the future in terms of DBS for depression? Again, anatomy and physiology are going to be the two important ones. And this anatomy point is really an important one. It's a beautiful demonstration of using connectomics to really optimize targeting. So if you just look at where the active contact was in responders and non-responders, they're really not much different. But if you look at the connectomic profile differences in terms of diffusion imaging tractography differences between responders and non-responders, the responders have this robust activation of prefrontal cortex, dorsomedial, cingulate cortex, medial temporal lobe through the uncinate fasciculus, et cetera, whereas the connectivity profile of non-responders is quite impoverished. So the idea is that if you target the electrode at the crossroads of these important white matter tracts, the cingulate bundle going to the cingulate cortex, the uncinate fasciculus to medial temporal lobe, and the forceps minor to the frontal pole, and you look at this intersection point and place the electrode there, perhaps you'll have better results. And so far, the results do look very promising with this strategy. A number of groups, including ours, is interested in the physiology as well. This is a study that we're running right now with UT Southwestern and a couple other places that is bringing the use of intracranial recording in stimulation that's commonly used, of course, in epilepsy surgery to the field of psychiatric surgery and in particular in depression. And we implant these patients with stimulating electrodes in the subgenual cortex in the ventral capsule and SEEG-style recording electrodes across frontotemporal regions of interest in depression. And we try to use the information gained from a 10-day inpatient EMU-style monitoring phase to then optimize the delivery of stimulation through those two targets, the subgenual cingulate and the ventral capsule. This is some results from our first patient showing that this individual got better in the months following this short EMU phase. And then we did a blinded discontinuation to disambiguate a sham from a true response. And indeed, the person got worse with the randomized blinded discontinuation, showing that, that it was a true response. We can also learn a lot about the physiology of these circuits from studies like this, where we have recordings, rich recordings throughout kind of prefrontal and temporal regions. And we can identify almost fingerprint-like patterns of activity in terms of spatial location, within the brain, anterior cingulate, dorsolateral prefrontal, et cetera, and spectral information that can individualize, the understanding of the neural basis of depressed mood. Other groups are doing this as well. This is a study from the UCSF group using recordings in one area, in the amygdala in this case, to modulate the stimulation output, which is done here in the ventral capsule. And so this is done with responsive neurostimulation, recording from the amygdala, medial temporal lobe, and then stimulating in the ventral capsule in order to deliver stimulation perhaps when it's needed in a more on-demand fashion. And then finally, this is a study from the Mount Sinai, Emory, Georgia Tech group, using, again, long-term recordings over several weeks to try to understand the neural basis of depression. Again, with the idea that the symptoms are not going to change on a moment-to-moment basis like they would for tremor or Parkinson's, but rather they're changing over days to weeks. And using this machine learning strategy, they were able to identify these features that loaded heavily, onto the outcome and predicted outcome. And in one example, they were even able to show that, a relapse indicated by the red and blue lines here was predicted ahead of time based on the neural signal versus what happened symptomatically. So again, studies like this and like the one I showed you earlier for OCD will help with the programming in order to tell the clinician, the psychiatrist, that someone is either on the right track or maybe headed in the wrong direction. And finally, the interest has been rekindled in depression such that industry has gotten involved again and started this trial called Transcend, which is a multi-million-dollar trial of subclosal cingulate DBS for depression, starting this year in 2025. And, within the next several years, a few years, hopefully, we'll have some results from that. And the basis, I think, in the future of this therapy, DBS for depression, I think will hinge a lot on what these results show. With that, I'll say thank you very much for your attention.